Welcome to TCNtalks, an Anatomy of Leadership. We continue our conversation in part 2 of Love Hurts, Leadership Quality, and the Future of Hospice and Palliative Care with the GeriPal Podcast. And now, here's Chris Como.
Court, what's your challenge? What are you thinking? What are you worried about?
You know, I think some of the themes that you've mentioned, the waste, fraud, and abuse is a concern. We have so many absolutely fantastic hospice and palliative care providers out there. And yet the country often looks at hospice as it's a, one-stop shop, like it's all one hospice, and they don't get the differentiation between the providers. So when you see an article that's talking about fraud or something inappropriate going on, it tarnishes the entire field. And that concerns me. I think we need to clean that up. The other thing that kind of comes to mind is around some of the ownership issues that a dozen years ago, we were talking about nonprofit, for-profit. Well, today we've segmented both of those. So there are articles out now about differences between church-based nonprofits and freestanding nonprofits. That's interesting. And then we segment the for-profit side into independent, publicly traded companies and private equity back. And what does that mean? I honestly don't think we have answers to any of that yet. We're participating in some research studies around trying to answer those questions. But there's a conflict between the mission and the money. And it's yet to be seen who's going to win and how that's going to impact patient care, which is what it boils down to me. If quality of care improves, ownership doesn't matter. Yeah. If it's going down, that's a concern. And again, ownership doesn't really matter, but we can probably segment this and unpack this a little bit more than we have to date.
Yeah. I think, the research that we have is that it does matter. So there's good and bad hospices, and there's heterogeneity amongst hospices, but there seems to be more heterogeneity amongst for-profit hospices than non-for-profit hospices, knowing that the field is evolving, right? Like, even in hospitals, we see that, nonprofits are starting to look a lot like for-profits in how they're acting and operating and what they're worried about. Is that your sense too?
We got to keep an eye on it. It is, absolutely. And the larger the provider, the more homogeneity there is, the more they all look the same.
Yeah. Chris, I think you're up.
Yeah, so my question is, since originally how we got together was around IRIS framework, what do you think of IRIS framework? And maybe for the listeners, I'll repeat it. Zero tolerance for waste, fraud, and abuse, clinical and programmatic standards, making meaningful data readily available, driving competition based on quality, embracing and promoting our authentic brand. What do you think about it? Is it needed? And what's your opinion about it? You've debated it, talked to them about it. Cord and I use it a heck of a lot.
Yeah, you use it when you talk about kind of every time you bring up those stories, you bring it up. Alex, I'll turn to you on this first. I took the first one.
I was just trying to put together my thoughts. I think it's a great framework. It's aspirational, and I appreciate that. I think I worry a little bit that it's unobtainable in the United States because we live in a system that is so capitalist and for-profit dominant, and where you can potentially end up playing whack-a-mole, squashing down one mechanism by which people are profiting off of people who are seriously ill and dying in ways that are concerning, because profit by itself is not bad. It's just when the profit motive leads to a decrease in quality that would become concerned. So I guess the critical part of me would say, can you really have zero tolerance? I mean, we should aspire to have zero tolerance for waste, fraud, and abuse. And we don't live in a country with a national healthcare system. And We are almost always being reactionary. I would love it if we could be more proactive. But I remember Eric and I were giving grand rounds at UCSF, and you pulled up this slide that you'd done some research like about not just hospice, but like for-profit ownership of nursing homes and assisted livings. And weren't they also like 70, 80%?
There's money in medicine.
Yeah. So for all like hospice, it is what it is. Like there are people out there who say we should have only nonprofit. I don't think Ira Byock's saying that. I'm not going to put that on him. But
he doesn't. He specifically says that he doesn't argue that. I'm going to be optimistic and say that's where our field has been. Like, oh, you know what? This is really bad, but it's not our problem. And I think that there are things that we can advocate for, and this is our problem. Like, if brand is important, like Court said, this is tarnishing our brand. If people are associating hospice with, people talking about fraud that's happening in places like LA, like they're associating that with hospice, then I have to have like 15 more minutes of discussion with the patients when I'm talking about that. And then I actually, like, even Medicare Compare, the reason I hate Medicare Compare is it starts off alphabetically. And if you're in a place like Los Angeles, it literally only goes to the letter C, because it's letter C, you're at 300 and it maxes out at 300. It's pointless. You could fix Medicare Compare, but that's not the problem. It's that you have over 300 hospices in one county, which is just insane. And I'm just going to plug one podcast that TCN did on Certificate of Need, because not every state looks like California. Not every state looks like Texas, right? Chris, can I ask you, what is Certificate of Need? Because our GeriPal podcast audience may not know that.
Yep, you bet. In a lot of states, I think it's about 26, 23. Court had actually looked it up for me. And so it's less than half of our states. There is a law called Certificate of Need. So the opposite, it would be like the state of Texas. There is no CON. I was having dinner with my godfather, a serial entrepreneur. Hey, Chris, what have you been doing in your life, your career? Hospice. Oh, my God, a lot of people dying. That's a great business. I need to look into that. That's the problem. And so states where there's a certificate of need, you can't do that. Actually, there's a formula that determines if there's a need. And so it basically creates the ability to create controlled competition to make sure people have choice, but you balance resources. And if the capitalists are like, that's bad, you should always have competition. I'm sorry, free market works when all the elements of free market are in place. You don't have all the elements in free market in healthcare, which is why you need CON. I'm okay with the capitalist system. I'm generally a capitalist in nature. But in healthcare, it does not work if it's just a free-for-all. If that was the case, hey, let's go to Texas. Let's go build a hospital in Dallas because there's a lot of people there. What about the poor people in Lubbock, Texas? You know what? We don't worry about them. We want to go where the people are. That's the point of CON, is it gets resources where you need it.
And let's be honest, the especially like in the hospital setting, the way people in hospitals get selected into hospices, it's not Medicare Compare. It's not a quality metric. It's who can admit this patient as fast enough so we can decrease our length of stay in the hospital for many hospitals. So this is not a true free market. And people don't have say. They don't even know where to look for.
But I am optimistic that's changing. With the baby boomers, I think we're on the cusp of a lot of sea change things blowing in the favor of things I think we would all believe in, like people choosing the best. You go buy a car, you want to get the best or whatever it is. Healthcare has not been that case. And maybe the baby boomers will be the generation of force. A lot of those good market things that it's not all free. You should have certificate of need and things. You have regulation and good rules and for a game to work. It's not, well, let's just throw all the rules out. Hell, college football has rules. And so with healthcare, we don't need a certificate of need. Well, what game does that actually work in?
Yeah, Eric, you were mentioning about your frustration with Care Compare. I recently had the experience of helping a friend of mine out. He was looking for an oncologist. I said, I'm in healthcare-ish. How can I help? So I went to Care Compare and I'm looking up, physician compare. And it says, well, this one's half a mile from your house. This one's 2 miles from your, like that was the rating. Like you said, alphabetical. For physician compare, it's by distance to your location. And I'm like, you know what? If the best oncologist on the planet for this particular disease is at UCSF, I'm flying to UCSF. Like that is not an issue. If I need to go to Mayo or, wherever, no problem. So mileage doesn't help me at all. And so how do we fix that? How do we correct that kind of a metric?
Yeah. Yeah. And how do we make sure that every hospice has a quality measure? So when we're looking at them, like how many aren't star rated in Medicare Compare?
Over 70%.
Like, why
don't have a star rating?
Why put them up there? Why name them? Like, we should shame them. There should be like a dishonor roll on Medicare Compare if they don't have a star rating.
Well said. Totally agree. And Eric, you started this by asking me my question about ARA. Alex, I wanted to say the brilliance of what ARA's done is we're talking about it. That's the brilliant. And he will tell you, he's gotten pot shots from the nonprofits and the for-profits. I'm like, that's when you know you're succeeding. You got him talking about it. You got him thinking about it.
I love that he started up and really started a conversation, pushing on this issue. Yeah.
Well, and I've been encouraging boards and organizations to consider, to talk about his paper and his strategies and assess, like, where are we today? What's our baseline measurement? And I like how he is empowering clinicians and people in the field, leaders in the field, to have a structure to think about, well, I can plug in and make a difference here, because we should all be plugging in to our spheres of influence, right? And maybe that's in the research circles, maybe that's in the hospital setting. How do we do that? And he's kind of issued the challenge to say, we should be involved in these conversations. We should not just be turfing this to Medicare and say, well, you made it, you broke it, you fix it. He's saying, no, we're the experts in this and we need to be in the conversations. And I completely agree.
I guess that my question to you on this IRA topic, because he didn't just mention hospice, he mentioned palliative care. Same thing, standards for palliative care. What do you think we should do there? Because this is a tough nugget, because hospice is a little bit standardized of what they should be delivering. And man, you see one palliative care program, you kind of see one palliative care program.
Absolutely right. And I think the challenge is there. What are the standards of care? And there are some standards that are out there, but there's not really that data collection and transparent reporting of results to compare. Like right now, I'm starting a research project across the state. We're contacting every hospital, every hospice, every known palliative care provider in the state. And it's really, we're at the beginning stage. Like, who's providing palliative care? How many consults? How many patients? What does this look like? What's your interdisciplinary team look like?
How do we define what palliative care is? Is it just like, somebody calling up and, setting somebody a squeeze ball? Which I have seen as somebody wanting to label that a palliative care clinic.
Exactly. And in Maine, many states have a definition from the state legislature, or you default to the World Health Organization or AAHPM or, whoever. Some CAPC's definition is often used.
Yeah.
I don't care. Like, pick one and let's evaluate against it, not just the presence of it, but to your point, Eric, quality. Yeah. Who's good at this? How do we actually assess quality in palliative care? And it's fascinating because it seems, in my experience anyway, palliative care has a much stronger research base behind it from the beginning compared to hospice. And so these questions have been asked at a much earlier stage in the game, which excites me. I think that's absolutely moving in the right direction. Alex, have you seen that kind of research in palliative care, separate from hospice in terms of assessing quality within palliative care?
I think it's just starting. I think it's too early to say we have good published data about that. And that's part of the problem with a lot of research in this area is there's a big lag between when data becomes available to study and when we need it. So I know people, including mentees who have grants to study this or have put in grants to study this, but it's probably years away from publication. I'm sure there are some people out there who I'm not thinking of offhand who are working on this. Okay, is it my turn? Can I ask a question? Can we shift topics? Let's talk about leadership. Chris, major focus of your work, your podcast, your book is about leadership, and you interview people on TCNtalks who are leaders in hospice and palliative care and leaders who are outside of hospice and palliative care. I'd love to hear from you and from Cord and from Eric what you have learned that is like take-home messages that are pearls of wisdom for our listeners about leadership.
I love that question. Thank you. It's very much in my place of passion. And I was thinking about what you were saying earlier, Alex, about these young people coming out and maybe the road is going in a different direction than what they're thinking. So a couple of great lessons I've learned over my life. I've had incredible mentors from growing up in corporate America, but yet I landed in hospice at the age of 25. You got to go see for yourself. The Japanese call it Gemba, which means go see for yourself. And no matter what I'm working on in leadership, like actually in about 4 weeks, I'm going to go out in a full day with patient visits in hospice. The beauty of you guys get to do still, you're in leadership, you're doing a podcast, but you're actually face-to-face with patients. I think it's important as leaders that no matter how your role evolves, maybe you're a senior vice president or chief of something, you got to go see for yourself. Always make sure you're still close to the action. Abraham Lincoln was always one of my heroes. I love always reading history. Abraham Lincoln had this amazing team of rivals, of leaders around him, but he had this news reporter and people on the battlefield that had the backdoor access to him, that it was ability for him to know what was really going on. He would go out himself. Those are great leadership lessons. And so now when you're young and face-to-face, be a sponge, all of that. But then as you evolve and you have leadership positions, don't forget some kind of way you've got to stay connected to the mission. And because you could get in your ivory tower and then be making decisions not based upon the reality. I think is the beauty of our just doing the podcast. You guys as GeriPal, your listeners are in the action on a day-to-day basis, hospice and palliative care. Most of my listeners are on the leadership side. And like Eric was pushing a court earlier, like, give me the specifics. And he was giving you a framework. That's exactly kind of leadership on a day-to-day basis. The leaders are given a framework. Staff's like, but this is where the issue is. You need both to actually get great outcomes. So that's the first one. Never lose sight of going see for yourself. Second is we live at a time where there's so much coming at us. Instant messaging, social media, your email, all the stuff. Where you put your influence is one of the most powerful tools that you have in your toolbox. But yet everything's coming at you to diffuse yourself. If you turn off the lights and you lit a cigarette lighter, it provides a little bit of light. A focus light is a I-beam or a beam of light would actually cut through a steel I-beam. Where you put your focus is huge. We actually call that influence in the anatomy of leadership. So as you go forward, if you're too diffuse, it's hard to make a difference. So where you're putting your focus and your influence is absolutely huge. And we live at a time where everything is screaming at you to go wide. And yet, I'm not saying just go very, very thin, but where you put your influence is going to determine what your impact is on the world. That's a huge leadership lesson. I wish I would have gone back and someone could have told me that in my early 20s.
I love what did the Japanese call it, you said?
Gemba, which I just say go see. Yep.
Like during COVID, that was for me a great place to see like who were the real leaders, like who were the people that I looked up to, and it was the people that were there, that were present, that were like that, and that really influenced me. Kind of how I think about like the leader that I want to be is you got to be there. How I don't want to use a battle metaphor, but like in the trenches is a good metaphor. Yeah. Court, what do you think?
I kind of echo what Chris was saying. I as a social worker background, I think about those grassroots movements and Robert Greenleaf's, the epic book, which is now probably 1,000 years old, Servant Leadership, that you think about the leader at the top who's making these decisions, but you have to have the feedback from everybody. And I remember being the CEO of the Colorado Hospice Organization, and one of the first things the board said was, you need to go out on patient visits with each member of the interdisciplinary team to understand what we even do. I'm like, I absolutely need to do that. And that was my favorite learning piece in that position, was just going out and like, I'm the tag along. And I loved that. The other piece that I would mention in terms of the leadership, I'm taking a class right now around AI stuff. And one of the questions posed was, what's the greatest obstacle to integrating AI into whatever your field is? And the first thought that came to mind was leadership is the biggest obstacle, that resistance to change. And, but really you need the support of the leaders in your organization, in your field, to actually create change.
What's yours?
I agree with this. I mean, there's so many good points could be made here. I like Chris's idea of having a focusing effect, that if you have a dark room and you light a lighter, everybody's going to look at that lighter, right? And I think it's critical, especially at these times when, as Chris was saying, there's so many distractions and different avenues you could go down, that you have some focus. But I'll also be contrarian here and say that if you look at my career, even though when I write my NIH bio sketch, I can try to come across as very focused, I'm incredibly unfocused. I actually give one of my standard Grand Rounds talks is Confessions of an Unfocused Researcher. Because I've really had more several areas in which I've had focus rather than one specific, dominant area of focus. But I think the underlying principle is that I'm dedicated to advancing hospice, palliative care, geriatrics, gerontology, aging research, serious illness research. I'm mission driven in that way. And if it aligns with that mission, then I'm all for it, And within that somewhat broad purview, I just love the intellectual curiosity of working with different issues, different problems, whether they're bioethics issues or epidemiologic issues. So I agree with the focus, and also that it's got to be interesting. You've got to keep it interesting and got to keep it fresh for you and for the people who you lead, right? They have to continually have a renewed sense of purpose.
Can I reconcile that, Eric, before you go I love where Alex just took it. Actually, I think, Alex, you just took it to the wisdom of the hospice model. Interdisciplinary work is one of the secret sauces of hospice. So in my focus, it absolutely doesn't mean you have to be monocular, but you take someone who's so curious like you. What I'd say, you're focused, you just took it to the mission, but you're also hyper-focused on being curious. And so I think you could still make that a superpower in your focusedness. And I think the future is much more interdisciplinary. I don't know what you think about Elon Musk, but he's brilliant in so many ways. He took interdisciplinary into the manufacturing area. No one ever did that. You had electrical engineer silo, the mechanical. He put them in teams and interdisciplinary. He literally adopted the hospice model in manufacturing and transformed it. So I think that we have some secret sauces in the hospice space, palliative care space, that are part of the future. So I love you took it in that direction.
I'm sure there are some of our listeners who would like to euthanize their Teslas.
Yeah. I actually feel from a Elon perspective, it's not the leadership that I look at, mainly because I think he takes credit for everybody else's innovations as his own. And that's the worst type
the flip side to it. He's a complicated individual.
He's very complicated.
To the intractable problems. You can think about money in medicine as an intractable problem. You can think about quality in palliative care. These are big, hard problems. I'm going to bring it back to hospice too. is, there was once a time a social worker / nurse / doctor who tackled an intractable problem, which is death and medicine's reluctance to actually care for people who are dying. That was Dame Cicely Saunders, who created the first hospice, and is still kind of like, when we think about like an interdisciplinary team in one, it's kind of her, but also somebody that we look at as somebody who tackled an intractable problem. Again, it's not like all of a sudden we fixed it. Many decades later, we're still working on making this even a better model of care. And that's kind of the leadership that, I think is important to model. Not just the fact that she had sherry behind her desk and that she had people drink sherry with her during her one-on-one mentorship meetings. You just break out the little glass. Alex can break out his guitar. We can have a little coming together. Well, Cord and Chris, I want to thank you to be on this podcast, our shared podcast, TCN and GeriPal. Thanks, Chris and Cord.
Thank you, guys. Thank you, guys.
And thank you to all of our listeners for your continued support.
So to our listeners, thank you so much. Please hit the subscribe button. And as we always do, we're going to leave you with a brain bookmark to close today's show.
In our work, there are days of amazing joy and days of amazing pain. By Chris Como. Thank you, USI, for sponsoring this podcast.